here. And get the encoder up and running. And Bob, we are good to go.
What is up, quarantine land? This is the one and only IT and the D show. We're all the way to episode 345. We got a phenomenal, we're very lucky to have a phenomenal guest this week, Mr. Fred Brown. He's an infectious disease expert.
I feel like this is every now and then we get a little serious. And I feel like just to keep us on our toes, we have to get a little serious now and again.
Oh, and by the way, happy birthday, Dave.
Thank you. I appreciate it, man.
But yeah, you made fire when ready, and we're looking forward to this week's show.
All right, cool. Here we go.
You're listening to the Podcast Detroit Network. Visit www.podcastdetroit.com for more information.
The following program is intended for mature audiences.
I'm Wyatt, that's Gary, you're Bob, and you're Dave. This is the IT and the D show.
This is Max Headroom. And what you're about to witness is one of the most sinister-sounding intros to a trailer to one of the greatest epics ever.
This is Billy D. Williams. Bob and Dave and I are enjoying a Colt 45 right now. And remember, IT in the D, it works every time.
Where do you guys think you are? The Library of Congress? Detroit? Beyond the sun? Any of those right?
Take him to Detroit. No! No, not Detroit! No! No, please! Anything but that! No!
You will never find the more wretched hive of scum and villainy.
Then don't come! Shut up!
Hey guys, it's Time Off. Bruce Leroy from The Last Dragon. You're listening to the IT and D show.
Hi, this is Christy Swanson, and you're listening to the IT and the D show. And Bob and Dave touch my hoo-hoos.
This is Guilfoyle from Silicon Valley, and the only two guys I hate more than Dinesh are Bob and Dave. Suck it, guys.
What's up, everybody? This is Billy Zapka. Sweep the leg. Listening to IT and the D show. No mercy.
I may have to wipe the guitar.
I just David Kay, the voice of Professor Xavier. Storm, come here, Storm. Sit on my lap, Storm. You're listening to IT and the D.
Are we at a break yet?
Everybody, this is Ted DiBiase, the $1 Million Man. You're listening to IT and the D. And if you want to get your money's worth, stay right here. And remember, everybody's got a price for the $1 Million Man.
This is the ladies' man.
Hi, I'm Ernie Hudson, and you're listening to IT and the D. All you nerds out there.
Nerds.
Nerds!
What is a nerd?
Hi, this is Ogre. You listen to a bunch of nerds on the IT and the D? Nerds!
I'm a nerd, and I'm pretty proud of it.
Hey, Detroit, this is Anthony Michael Hall. You're listening to my buddies Bob and Dave on IT in the D.
Hi, it's Count Chocula, and you're listening to IT in the D. What the hell did I do?
Hey, what up? This is Jay Muse, and you're listening to the IT and D show. Snooch to the nooch. Listen, Muse, Snoogans.
This is Scott Steiner, Big Pump Pump. IT and the D show is your hookup. Holler if you hear me.
This is Robert Hayes, Jet Striker to my mother. When I'm not hanging out at my gumbo bar, I'm listening to the IT and the D show. It's worse than Detroit.
Is there such thing as a meat hangover?
I love my Monday meat steak.
Hi, this is Jeremy London from Mallrats, and I'm just wondering, how did I go from Hot Floridian Sex with Brandy spinning to the IT and D show?
Hey, folks, this is WWE Hall of Famer Hacksaw Jim Duggan, and you're listening to the IT and the D show. Tough guy. Ho!
Dig you IT geeks. This is Dre DeMatteo from Sons of Anarchy. You are listening to
Dave is skeptical.
Hello, everybody. This is Ning Chen from Aces Comic Book Fan. I'm a techie. I'm a nerd. I'm a podcaster. My favorite podcast is IT and the D.
Hi, this is Kelly LeBrock from Weird Science. So, Bob and Dave, what would you little maniacs like to do first?
The question isn't what are we going to do. The question is what aren't we going to do.
Ludicrous speed! Sir, how'd you better buckle up? Fuck all this! Ludicrous speed! Go!
Hey, what's going on? How's everybody doing? I think our guest just fell asleep with our intro. This is the one and only IT and the D show. We made it all the way to episode 345. Do the math, Dave.
So that's Bob's wrong plus 329.
Close enough. Find us online, itandthed.com. Do us a favor, give us a like on the socials and subscribe to us everywhere. Fine podcasts are sold.
Yeah, and yet again, this is usually the point where we tell people about our upcoming events, and we don't have any. And the reason we don't have any upcoming events is why we have our guest on the show tonight. So yeah, I guess without further ado, let's go ahead and dive in and talk about, God, I guess the only topic that's dominating conversation these days. Oh, you got yourself muted. Oh, you got yourself muted, Fred.
Fred, you're on mute.
There we are. How's
there
that?
There you go.
Hey.
I apologize. There we go. I'm off and running. Well, thanks for having me, Dave. I appreciate it.
Of course. No, I appreciate you taking the time to come in.
Absolutely. It's a pleasure. Well, I want to get the word out about, what to expect a little bit with this. I've been in this game since 1984. I actually helped develop the first the first AIDS test with a company called Centocor. And we were lucky enough to find you develop the first definitive test for AIDS. And from there, that was 1986. And then from there, I helped develop 6 or 7 war vaccines. In fact, if your guests have children, then most of them have been vaccinated by my vaccines in the 1990s that we developed. And I've been involved with probably 7 or 8 pandemics. We have an epidemic about every 2 years. People don't really realize it because they're able to quell them down. But they're reasonably frequent. And so if you think about Ebola coming around twice, and we had a Zika virus scare, which I was involved with, malaria I've been involved with, and failed to quell 3 times now. So it's an interesting game, and welcome to my world. I'm looking forward to talking a little bit about it. I wanted to go a little bit maybe into background. I gave a talk to Harvard. The fellows were interested in what was happening, and so they asked me to give a presentation. And I got a little bit of that here, just so people have a little bit of background before we talk about what's going on in Michigan.
Okay.
So right now, I guess my full set of credentials is I've been in drug discovery, drug development, and vaccine development for 35 years now. I've developed 27 major drugs, 6 vaccines, 13 major diagnostic products. I was head of Roche's portfolio management team. I was global head of that for several years. And you'll hear a little bit about my experience managing the H5N1 epidemic that went into Europe. And we just were able to contain that. And I've created a tool that I think can be helpful for the audience to eventually take a look at and see how we're doing with the COVID.
So what you're saying is you're not some guy in a mask that I found at Meijer to just hop on the show.
No, I'm working with Johns Hopkins. So if you guys are looking at that, sadly, I helped convince them they should put up this this clock just so we could watch the virus come up and then come down again. I thought it'd be fun. And,
So you're saying
this all the time.
You're saying though you're one rung below a politician on their knowledge base on infectious disease.
But he's somewhere underneath a Facebook certified epidemiology expert, and somewhere above. Yeah.
Hey, Fred, let me kick this off. I just got a quick question.
Sure.
So I've lived. We joke around. Like I call our 2009 vacation to Mexico the swine flu tour. Because the swine flu broke, and then we didn't know we should be flying home. Every 2 years, something's going on, bird flu, SARS, you kind of listed off a few of them, also the Ebola and all that. Like, what's different now? Like, why this one? Because again, I don't mind doing all the stuff the government, everybody has us doing. It wasn't that, but I walked into this going, it's nothing. I've been through this crap, and it's something.
Yeah, we sort of got caught with this one, and I think we're
Verner's and Robitussin is not curing this. That's what I.
Yeah, people keep comparing it a little bit to the flu, and I'll go into a little bit why that isn't the case. So with this one, it's funny. We actually do prep work. So in Europe and in Asia, we do a lot of prep work, and in fact, it's called Prepare. And every 2 years, we go through a couple of scenarios. And what was interesting was the U.S. was part of that in the early 2000s. We went through the prep work, and we did so badly that we decided that we should develop a plan for it. And in 2008-9, we put together a plan, part of Bush's administration, then moved into Obama's administration. We thought it was a pretty good plan, but it was sort of, it's not that important. We'll wait on it. But what we found out was there are a couple scenarios where we do really, really badly. And this particular virus is one of those scenarios. It's human-to-human transmission. That's the first problem. So it's, we've got a lot of population. People are close together. They travel together. We're global today. So anything any small population can move in human, can travel to a place and really cause pandemics. That's the first problem. The second problem is mode of transmission. This thing is really infectious. And so if you can start to infect people from, just breathing and coughing, and the molecules and the aerosols stay in the air for enough time, up to 3 hours, actually, unfortunately, that really is a bad scenario, because if you think about the AIDS virus, it's sexually transmitted. If you think about Zika, it had a vector of the mosquito and so on.
Right.
We were able to stop it at the vector, but here it's just out there, and so it's and unfortunately, it's got a reasonably high kill rate. It's sort of moderate for viruses. If it was a higher kill rate, actually, it would probably die out because it would lose hosts. But this one is just sort of in the perfect area where it kills enough people that it's able to survive. And then we've got the transmission problem, and the transmission problem is a big one because we have a lot of asymptomatic carriers in this space.
So viruses are getting smarter, is what you're saying. Great.
Oh man, yeah, we started to select for the smartest one, and we've got it this time. And this guy is hard to create vaccines for. We still don't have any vaccine. If you think about the common cold, we've had it for a long time. We've been trying to stop it for a long time, and it's one of the coronaviruses we don't have much against these guys. So we've got a little bit of a ways.
So and actually, and there's a good starting point, because I've heard people use those terms interchangeably. They say coronavirus, they say COVID, they say COVID-19, they say so. From a science perspective, lay that hierarchy out.
Absolutely. So this is called the scientific name is SARS-CoV-2. So it's a SARS-related virus, and we've had two epidemics of SARS-related virus. One was the first one was SARS, and then we had MERS. That was Middle East virus. The Middle East virus had a very high kill rate, and luckily died out in the Middle East. SARS almost got over here, and we made it all the way through Asia, and then all the way to Canada, and then all of a sudden just sort of petered out. This one is not petering out. So this is our second SARS-CoV, and it's COVID-19 because it was found in 2019. We've actually have about seven.
So it's not the 19th iteration of it like you see all the Facebook memes of. Yeah.
If it was mutating that fast, we'd be in real trouble. Trust me, we would not want that.
Rocky 5,000.
Oh, so it's a tough one, and I thought one of the things I should show people is something about. It's important to understand why we're having so much trouble, and what's funny about trying to manage viruses, and that is that they have exponential growth. I didn't know if your audience really understood exponential growth. I can give you a first sense of it, and then I wanted to show you a slide or two that actually showed what really happened, and if it made sense, I'd have to.
For sure, absolutely. So and that's the thing. We used to think we had a very IT-centric crowd, but then we've learned we have a lot of folks that aren't in IT that listen to us. So from an IT perspective, we're familiar with, computer viruses and that kind of stuff and dealing with that. But I would say assume nothing and start with layman terminology and go from there.
Okay, well, so what's interesting about the computer crowd is they understand networking, and working, and to think about networking and how important it is. It works as n times n9 is 1, right? So you guys know, exponential growth once you hit the network. To give you a sense of this network, it took us about 4 months to kill 1 million people, and then we killed another 1 million people in 12 days. That's exponential growth.
Mm-hmm.
So let me explain why that's so hard to manage. Yeah, that's sort of a wild little statistic, isn't it?
Oh yeah, no, those numbers really kind of hit you like a sledgehammer in the forehead. Yeah.
Yeah. So once this baby starts getting going, and I'm just showing a slide now, I'll show you what happened in China and why they were thought. So here, what happened in China? This is actually what happened. And I know a lot of those guys over there, and they said, when we first started off, we found a couple of infected people, and we even had a death, and we found a couple of infected people. So at day 5, for example, if you see, if influenza, you'd expect to have about 1.5 people being infected. Now with COVID, what happens? So it has a 1.25 infection rate. In 30 days, you'll go from the first case all the way through. You do the math, and you get 15 cases. Pretty manageable. You got 15 cases. Okay. Now COVID has a slightly higher R. It actually has about a double the size R. It has a 2.37. I just use 2.5.
Yep.
To make the math easy. But here we have COVID, and if you let the infection go for 30 days with COVID, but think you've got influenza, you don't have 15 cases to work with, you've got 406 cases. And if you wait another day or two, you've got thousands. So that gives you a sense of just how fast you have to act. And unfortunately, we're used to sort of sitting back saying, let me take a look, let me figure this out. All of our systems, everything, processes are linear, But this guy works fast. Once it gets started, it goes fast. So what happened in China is that they decided that, hey, I think I don't think it's influenza. They started seeing this curve coming up. So we said, let's stop. Let's put in social distancing now. Let's take this seriously. If they had, so at about day 12, they stopped. They said, no, we're going to take it seriously. We're going to go after it. If they had actually made their decision a week earlier, they would have only had half the cases to worry about. If they'd waited a week longer, they would have had 9 times the cases to worry about. So, you can see that decision. You've got to really be able to hit it fast, right?
So here's my thing. The analogy because again, computer guy, the analogy I keep coming back to is I'm having so many flashbacks to Y2K right now.
That's right. That's a great example.
Because it's so hard to prove the effect of a negative.
That's
like everybody's like, oh, that was such a joke. There was nothing really going to happen. No. You don't understand how much work went into nothing happening. And so like I don't think people understand math like this and just exactly how scary, insane things can get so quickly like this.
Yeah, these biological systems really go fast, and we're just not used to working with them in our day-to-day life. Working, one-to-one, slowly making our decisions, thinking it over, and it was funny in Italy. A friend of mine is in charge of North. I ran Europe, and so for Roche, and Italy is right next to us in Switzerland. And so I dealt a lot with the Italian border, equivalent of the CDC up there, and I saw what was going on in Italy. I was kind of monitoring it. I said, I called him up. I said, "You've got a serious issue." He said, "Yeah, I know. I went to the prime minister. I went and talked to the head of Milan, mayor of Milan, and they said, 'What are you talking about? Everything's great. We got everything in control. We got a couple of deaths here and there, but it's good. And besides, we're coming up with weekend, and so they let it go an extra week, and that's what happened. So
and there's your number on what an extra week means. Yeah, wow.
Yeah. So what was fun? So I'm a consultant. And I had lots of clients, and I was working along, and all of a sudden, in the middle of February, I told all my guys, I think this is going to be serious. I want to stop consulting now, and it's going to focus on this because, we've just had a mistake in the CDC, and so I think it's better I work on this, just focus on it. And so the result is everything I'm doing right now is free. I want everyone to understand it so we can get out and get a good solution to it. If everyone understands, we'll get that much better.
Yeah, kudos. Wow. Thank you. That's awesome.
Well, it's a pleasure. But, but what was interesting, all my clients said, "Oh, sure, go ahead. You'll be back in a couple of weeks. It'll be fine."
Yeah.
So here I am. I got my self caught in the tar.
Hey, Fred. Yeah. Hey, Fred, a quick question. I don't know if I'm jumping too far ahead or
no. Go ahead. Absolutely.
I really like the misinformation that's thrown at us is obscene these days, and I just want to throw a couple of things at you because I know you hear hey, the hospitals are packed. Then you hear they're not. Then you hear the hospitals get paid more if they classify COVID, and then they get paid a lot more if they put them on ventilators. And there's USA Today even fact check that is true, but it seems weird. And then you have things like they're not classifying anything else as a death. So regular flu deaths are stopping, and they're classifying everything as COVID. I mean, how do we make sense of any of it, or what's real, what's not?
Yeah. So a couple things. The first thing I would say is don't trust anyone who's really confident, because no one really knows. I'm in this game for a long time. I talk with, experts in the field all the time. We have our own arguments about what we think death rates are, what we think prevalence rates are, what we think the R's are. We'll get into that in a little while. But, so first of all, don't trust anybody who isn't coming to you with real data. And the USA Today reports are about, are accurate. They have some of the data, but they've sort of selected it, and you can't do that fairly. So I'm sure there's some incidences of people, pushing the envelope in terms of quantification of diseases. But I'll tell you, most of the people I know, well, first of all, several of them have died, sadly. Most people I know who are on the front lines are working 12, 15, 16 hours a day, and these aren't normal work days. These are really high stress work days where you're dealing with death. You're trying to help people, save people in the last minutes of their lives. You've got to be really on all the time. And so, my heart goes out to them. They're working super hard, and so if there are a couple of mistakes made here and there, I give it to them. What happens is, interestingly, what we're finding in COVID is that it's not, if you're in control, and some of this is luck and some of it's great management, but if you're in control, we have the capacity in our hospital systems to actually manage it. What happens though, if you have a sudden outbreak, and you'll see, if you make a slight decision like New York did of keeping the schools open an extra couple of days, those small little decisions really start to overwhelm the hospital systems. And once the hospital systems get overwhelmed, and they're already close to capacity anyway, and they're not used to dealing with COVID. It's a brand new disease. We don't know anything about it. So once those things happen, you have a very high fatality rate if you have an overwhelmed hospital system. Usually it's 2 to 14 times higher than if the hospital system they're just proceeding normally and has it under control. That's why we're so concerned about whether you're going to do a peak or not. Because if you can't control that peak and you start to really go over it, you have a really high fatality rate with this particular disease. If you're able to manage it, it's not too bad. It's doable. It's probably, we think it's about 5 to 7 times worse than the flu, but at least it isn't 20 times worse than the flu, which you get with Ebola and others and AIDS. So so my counsel is to, first of all, scientific literature. Don't believe anything that isn't peer reviewed. And you really look at the methodologies used, because there's a lot of stuff going out really fast to try to demonstrate something and prove something. Usually those studies are fairly biased. They're looking at, they want to prove a point that they already believe is the case. And so if you look at the experimental design, it's flawed, and a peer review will kind of come through. Take a look at it, absorb it all. But unless you're talking to a real expert, a medical doctor, an epidemiologist, a drug designer, I'd try to understand where they're coming from. I mean, they have a job, they have a representation they have to make. I don't have those restrictions, but most of my colleagues do, and they keep pretty quiet.
Well, that's the thing. I always talk about, follow the money. That's going to tell you where the agenda is. And it just seems like there really isn't an agenda, though. It's like some people are so heart set against this being a thing. There's some people that are so set against this being a hoax. There's some people so paranoid about and there's no angle. I don't, you know what I mean? I guess it's just they're formulating their own hypothesis and then they're kind of just running with it.
No, so there are a couple things. First, I hope that we have a solution pretty quickly. But what's happening in the news media, unfortunately, is actually, why don't I show you that? Because I had to explain this to the guys at Harvard.
I guess let's start with the big one. Do you recommend bleach injections and UV lights down your throat?
Please don't do that. Don't do that. The president is under a lot of stress. He's doing the best he can, I think, under the circumstances. But we all screw up.
Yeah.
that was a true screw up, sadly. But I like the fact that he's trying to at least put this on the table and talk to people about it, and I think that's positive. Unfortunately, whenever you're on TV as much as that, I'm not on that often, so I don't have as many screw ups. But everyone screws up a little bit. So
yeah, 2 hours a day can be a bit much. Yeah.
But here the situation is, questions. Okay, how do we proceed? And the thing that bothers me when I listen to the news media, especially up until about the last few days, is most of the people think that we're going to have a vaccine in 18 months and everything's going to go back to normal. And even between that, we'll have a once quick peak and then we'll be done and we'll wait for the vaccine to come and then everything. And it is possible. I don't want to say that it's impossible, but it certainly is not probable. What is more probable is, and the second option, of course, as you said, is let's just let it run. We don't think it's that bad. We're not really sure yet, but if we just let it run through, people get herd immunity, and it'll look like a Spanish flu. We'll have a little bit of population crunch, and then we'll be done. And I'll go into that a little bit in a second. The last issue, the last option here is that this is going to be a long, hard slog. And I think it's going to be my experience is that these are long, hard slogs. And so if you're managing a business out there and you think that everything's going to be fine in May, that's fine. You want to hope for the best, but you want to prepare for something that's going to last. My guess is at least 18 months of this kind of management of, can we open up the economy, close down the economy, open up the economy, and we'll talk about how we can do that more effectively in a little bit. But
I have never wanted to rely on get lucky as a strategy. Let's just be clear. And actually, I was just talking about this the whole Philadelphia thing, specifically with the Spanish flu back in 1918. The war bonds parade that they did. That
That's
hey,
right.
we're going to go ahead and we're going to relax the restrictions before everybody else says we should, and we're going to hold this giant ass parade. And within like 5 days, every bed in the 41 hospitals in the city were full, and people were dying by the tens of thousands. I mean, that's insane.
That's what we want to avoid. Because then you start to overwhelm everything, and you get a real, then you have this. So I don't think this is just a period of time. I think, like the Spanish flu, I think this is going to be sort of an era. There's going to be a new sadly, a period of time that we refer back to as the COVID era. And I wish it was just a blip, but I don't think it's going to be a V-shaped, recovery or anything like that. I think it's going to take a little time.
We wanted the wonder years. We got the COVID years. That's great.
That's right. So in terms of getting lucky, which is your first hope is, right now, I'll tell you, I've developed 6 vaccines. It took me about an average of 9 years each vaccine.
Wow.
These are proven, yeah. And actually, I'm better than most. Usually it takes about 13 and a half years to develop a vaccine for a novel virus. So, on a normal platform, proven, scaled, ready to go with you start from scratch. Yeah, you're talking about 13 years, 14 years. Right now, we don't have a single vaccine for a coronavirus. Everything we've tried for for MERS and SARS hasn't worked. So, right now there are actually over 100. This is from I gave this presentation on April 4th. So to Harvard, and they published it in world record time because they thought it was important to get out. But basically, the good thing is we got a lot of shots on goal here. So we can afford to have a couple losers and we got the whole world working. Half the COVID vaccine candidates are actually in China. But they're right now, we're still kind of getting a sense of where we think we can go. And, one of these days we can talk about my area really is drug discovery and vaccine discovery. And we can go into a lot of depth on those options. But today I just want to talk a little bit about the IT implications for this. And then we got lots of committed resources. Almost every major vaccine manufacturer, with the exception of Takeda, is in this big time, and said they're going to put $1 billion into it. But my guess, if I had to say, if we, everyone's saying 18 months to a vaccine, my guess of that occurring really is less than 20%, based on my experience. We could get lucky, but we're talking about everything working perfectly. And, I know all the tricks, and we're talking about, ring trials and ways of looking at master protocols and having, parallel manufacturing scale up while you're doing phase 3 studies.
Right.
And doing phase 1, we're talking about every possible trick in the book. Even then, I'm getting 19 months, best case. So my suggestion is we probably should have another plan, just in case. I'd love it if
Hey, any good IT guy will tell you to have a contingency plan. That's
right.
We're
you always want to
good.
have a little bit of that extra 20% in the bottom of the effort levels.
The contingency plan, and then we'll talk about disaster recovery. That's
right. Well, right now we're in disaster recovery, so we know how that goes. So the other option is, people say, look, I'm a young guy, I'm strong, I'm tough, I can take this. Just let it run right through. We'll get a herd immunity. We'll have some deaths, but overall, we'll also have some deaths if we shut down the economy this way. There's a lot of economic trouble, right?
Yep.
I mean, and people
What did you call this, Dave? What'd you call this, Dave? The chickenpox parties when we were kids?
Yeah, This isn't like when we were kids and our parents would get us all together because one neighborhood kid got chickenpox. All right, you're having a sleepover at his house because you're going to get it and get it out of the way.
That's right, and it might be when we know more about this that isn't a bad decision. But right now we don't know nearly enough about this. My guess is that's probably never going to be a good decision. But don't do now. That's for sure. Do not do that.
Yeah, I believe we've seen studies showing that people have been reinfected in South Korea. So getting it once is not a guarantee that you won't get it again.
Right. And that's something we don't even know if the immunity is going to, how long it is, how confirmed it is in terms of preventing disease. We don't know those numbers yet. We think based on SARS and MERS, we're going to get about a 2-year immunity. That's going to be pretty good. It's based on a lot of different factors, though. It could be as little as 12 months or even less. First of all, it could be slight or it could be full. We don't know that either. So as you said, Randy, there's a lot of risk in terms of going after this because it may not even work. So it's a big bet right now, and I wouldn't. A lot of states are saying let's just go for it. I don't think we're ready to do that yet. If I had my brothers, because I think we have a better way of managing this, even short term. And don't forget, this thing is all in, right? If you start the herd effect, it's really hard to stop. Because let's slow it down. We made a little miscalculation. It has all sorts of side effects we know about. It kills more people than we thought, and then you want to stop it. You really can't. It has its own life. And so right now we don't have any drugs and we don't have any immunity and we don't know much about this thing. So I would take it, slow and careful and learn as much as you can about it before you have to really have a big fight.
For
We
sure.
gotta just jumping around real quick. We got a quick question. Have you seen the Dr. Erickson video on COVID? Do you have any thoughts on it?
I haven't seen it. No, tell me about it.
No, someone just put in the chat box on the video.
I don't know Dr. Erickson. Where is he at?
Don't know. I have no other details other than I guess we'll be Googling it after the show.
I'm happy to take a look because there are a number of people who so there are a number of studies where they're trying to do this. In Germany, they're trying to do this. There's a guy named Professor Schreek, Schreek, and he's sort of in the middle of Germany. They had a lot of COVID there, and he has 100,000 tests that he wants to do on a population that's quite structured. And he's going to look at what he thinks the right numbers are to do better policy judgments. And it's going to take him a few years. He's already released the first part of that study, and it's pretty interesting, but it's far from conclusive. There are a couple of guys at Stanford who are also advocating this. They're saying, look, we don't think it's that big. We're not really sure, but we don't think it's that big. So why don't we just, block off a part of the United States and see what happens? And so they've actually, submitted grants to do this. And my guess is that there are countries that will do that, but hopefully not in the United States, because that you're really kind of asking for potential things to go really wrong.
Well, isn't Sweden doing this? Isn't Sweden doing this right now?
Well, yeah, it's interesting. Sweden's Sweden is very interesting. They decided to go ahead and do this. They're protecting their older people, which is smart, because the older people, we look at the death rates, and they just, if you're my age, it just starts to take off. There's almost no deaths unless you're compromised until you're in the 40s. By the time you get to 50, now this is talking population level. I'm not saying as an individual you should go out and feel safe, because there are a lot of instances where you've got. So at a population level and a statistical level, it really takes off with compromised patients and older patients. And so what they've done is they said, we're going to shelter all the older patients, shelter all the compromised patients, and then we feel like we're not that population dense. And we are going to do some social distancing, but we'll keep some of the things open, and we're just going to see what happens. Right now in Sweden, everything's pretty good. If you know Sweden, sun 24 hours a day. They're out on the islands. They're not really concentrated. Once they get into fall, I'm a little bit worried that it might come back to get them, because people are blocked in more. It's November, the flu season's up, and all of a sudden I'm just concerned that we might sit back and then they're going to get in trouble. I think
those are the two things that I heard, whenever that discussion about Sweden comes up, the two things that I keep reading and seeing are the population density issue, and then they've got universal health care. So they don't have quite as many issues with underlying conditions and pre-existing conditions like we do here.
Yeah, they're healthier than we are, no doubt about it. That's true, and they have quite a So we're all watching Sweden very carefully. The other countries to watch actually are completely the opposite. Both completely opposite is Taiwan. Taiwan, these Asian countries got ready because they had SARS, and so if you're in Taiwan, you go to a hotel and your phone. And my friend had this happen; his phone shut off. lost battery power. And at 7:30 in the morning, 20 minutes after he lost battery power, there were police at his door, in his hotel door, and he was quarantined for 14 days. So that's the, and they can run their diagnostics.
Wow.
It takes us about right now with pent-up demand, it takes us 5, 6, 7, 8 days. Korea, 7 minutes. So you can get a sense of just how much faster you can react if you if you can get that kind of a throughput. That's really nice.
I keep joking and saying this episode of Black Mirror sucks, but I mean it sounds like that's actually not that far off.
Yeah, no, it's we're so there are different strategies, and we're lucky because we're a little bit after everybody else. We can sort of look and see and go, what's working, what's not working. So that's actually an advantage to us if learned from the other groups.
Yeah, and I think that was one of the things that I remember. There was the all the YouTube videos that came out, the folks in Italy. If leaving a message for themselves 10 days ago. And basically as a warning to us that, hey, this is where, that's where you are right now. Here's where we are right now. Open your eyes. And again, we were all kind of, like I said, I mean, I have no problem admitting that I was a little flippant about this when it first broke. And, and it was, until the numbers and the data really started coming out, it was like, yes, we actually should take this seriously. Okay.
Yeah, my life is that doomsday clock. Every morning I wake up and it's on, and you just see, how many deaths have occurred, and that's reality. And luckily there have been some areas in the United States that have been skipped, and that's great. Celebrate, because next time it's going to come around a few more times. We'll see.
And for sure. I mean, and a lot of those areas, it comes down to some things we were just talking about with Sweden. I mean, no, South Dakota and Wyoming aren't seeing huge outbreaks. They don't have the population density that a New York City, a Detroit, a Chicago, do. So
what was interesting, there was a study out of University of Texas, Dr. Murray did it, and she's very well known, very great epidemiologist. And they said, if you're in a very rural area of the country and you see zero evidence of COVID, there is a 9% chance you're actually having an epidemic. And if you see one case of COVID, there's a 50% chance you're having an epidemic. I don't know. I looked at the paper. I said, "Well, the math all works, but holy moly, this is quite a conclusion."
Wow, yeah.
Well, what's your take on California opening up the beaches already? Because I thought that was a little bit premature, but
Actually, I'll tell you, I can see it in the data. And I'll show you that in a little bit. How accurate some of this data is quite interesting. You can actually start to see what they call reproductive rates of the virus starting to inch back up. And California was in very good control up until this weekend, and now it's out of control. It happens that fast. You don't notice it. It's we had a nice time at the beach, but in 2 weeks you're going to pay. Yeah, it's too bad. They didn't hold on quite long enough. And you have to keep, you can go to the beach, but just maintain your social distance, try to see that 6 feet. And they weren't, and so I think that sadly we're going to see we already see a blip, and I'll show you that in a second. So what I gave to the business guys, I said, look, they're going to probably be 4 different, we don't know.
Spontaneous combustion, I love it.
we don't know. So if you don't know, let's think about some scenarios and how likely they are. So I said, there's it could be like SARS. It reaches Canada, and all of a sudden the whole thing is, we don't like it anymore. We're just going to shut down.
We're done. Yeah.
We're good. We're good. We had our fun. We're done. It's unlikely that's going to happen. But I gave it a 1% chance. The magic bullet is the one here all about, and everyone's sort of counting on, right? 18 months, we're going to have a vaccine. We'll all go back to normal. We have to kind of pay for a little bit of the economy in the meantime, but everything's going to be wonderful. I give that about a 20% chance. Unfortunately, I wish it was bigger than that. But if you talk to epidemiologists and you talk to guys who create vaccines, they're going to tell you, the chances of success before you get to phase 3 which is all the way through a vaccine development, it's about 15%. So therapeutic cocktails, good chance here. I think we'll be likely to. This is the most likely thing will probably have happen, and the worst thing that could happen is, even though we're working very hard on this, everyone's active at it, we have all this new technology, it still takes about as long as it ever does before, and that's 10 years. So those are the sort of, and I give that about a 20% chance, because I think we got a lot of good stuff in the pipeline. So, here's what it looks like. You can see the different options. But So spontaneous combustion we've heard about. Magic bullet means we've got a vaccine in 18 months. Therapeutic cocktails is much more like the way we manage AIDS, for example. You know, we don't have a vaccine for AIDS, but with a good cocktail and it's tailored for you and you're monitoring very carefully, you can really suppress the vaccine and sort of suppress the HIV virus enough that you really don't even have a count anymore. Because
you realize there are people's heads exploding right now reading those years across the bottom of your chart, right?
I'm sorry about that. I should have covered those up, I guess. I don't want to be responsible for that explosion. Yeah. When I'll tell you, when people see this, this is sort of the time frames we use to develop drugs. Normally, it's like, okay, in 15 years. So, step 1, step 2, step 3, phase 1, phase 2. We can do a lot to do things in parallel, but you also take a lot more risk when you do that. So you have to kind of balance that. And you can see it typically, it takes about, if we're lucky, 10 years plus to develop a real full-blown, okay, we've got some plasma therapy, okay, we've got some repurposed drugs, okay, we've got a couple of cocktails that really are designed just for this, and eventually you get the vaccine. That's usually what happens. So hopefully it will break that paradigm, but that's sort of what it looks like.
See, I thought you were going to be more like a therapeutic cocktail.
That's right. I'll take one of those, and with that, I have Newt and a little maraschino cherry, and down.
Exactly. We're all about the therapeutic cocktails.
Right.
I'll have to bring my cup next time. I didn't realize. So I think so what's interesting is what I'll talk. Maybe we should just talk a little bit about where we're at right now, and then I'll show you what we can do about it. And I won't talk about drugs and vaccines because I think it's a little bit further on. We can always come back to that later if you want to, but maybe we should just talk about what's going on now, which is
absolutely
all we have right now. Really is social distancing and diagnostics. We don't have any backstop. So if this thing starts going at us, all we can do is try to prevent it from hitting us and allowing it to reproduce. And so if we know where it's coming from with the diagnostics, we can then separate away from those everybody who's contagious from us, and we can reduce the viral load in the environment, which is great, but it costs a lot of money as we see. That's a big unemployment. Then we have the drugs. Once you have a drug, that was what I was dealing with Tamiflu and H5N1. I had great diagnostics. I was working at Roche. We had 80% coverage. We had about 8 times the coverage that we do in the United States right now. 800 times the coverage we have in the United States right now for this particular area. And I had a backstop. I had Tamiflu. So, and even then, even though I had that much coverage and I had a drug at work, at one point it was close to going out of control, even with that much support. And then when you get a vaccine, of course, then you really have back to normal. And then you can start to say, especially if it's a full vaccine and full immunity, and everyone gets enough of it. Probably about our case, it'll have to be over 80%, probably 85% of the population should be vaccinated. At that point, you can really say, okay, I'm good. I can avoid getting this disease, and we can go back to normal. But that's sort of where we're at. And what's interesting is once you're in one of these boxes, there's not much you can do, to improve your performance, to really fight. Your effectiveness is really limited. When you jump to the next area, so when we get our first drug, we'll be able to do quite a bit more. And when you get a vaccine, then of course you can do an awful lot more. So, once you're in this box, and we're in the social distancing box right now, you don't have many options. And but hopefully we'll move quickly to the next and the next. But this social distancing is all about human behavior, and as you know, it's highly variable. If people feel good about it, they'll do it. If people don't feel good about it, they won't. And
well, and honestly, I mean, we've had that conversation on here before. It's, the sad reality is we are forcing our government to legislate for the lowest common denominator.
Well, and it's really unpopular to do something that doesn't look like it needs being done. But as you know, with the exponential growth, sometimes you got to take a stand and say, wait, if it goes off, I can't control it, and I'm going to have overwhelmed hospitals. So that's sort of the idea. Right. And
I think that's the consensus too, is everybody thinks that the vaccine's going to come out in like 2 weeks, and then we're going to go back to business. That's what everyone you talk to, like, oh yeah, when the vaccine comes out, then we'll go out, and I'll see in 5 years,
that's the, so
Dude, I'm gonna print out that one slide with all the years across the bottom. Like I'm gonna print it out by the thousands and just start leaving them in people's mailbox.
Well, this is the other two slides you should probably show them, because it's great if it happens, and if it happens, that's perfect. But you don't want to count on it,
Right.
That's the problem. I don't see many other alternatives out there other than people saying I'm going to count on it, and when you really talk to people who've done this before, they all say, well, it's probably going to be a little longer. So you have to watch those kind of words, right? I'm hopeful that. I think that maybe it's possible that. Those are all true statements that people who, are epidemiologists who know that it could be 15 years, but we're hopeful that it could be. If you listen to Fauci, he'll say that all the time. I'm hopeful that. Anyway, I agree. I hope that too, but the realistic number is probably the one. Anyway, we've had this once and done, right? So China went through this. It went up. It came back down. You can see that they had a peak case on February 5th in the slide. And then, by end of March, they said, okay, we've got it down now. And so we're going to ease travel restriction. Now, that really wasn't so much the case. They let people into restaurants, but if you want to eat in China, initially when they let you out, they had to wear N95 masks, and they had to take them off and put it in. Everything you got was, sanitized and in plastic wrappings. You had to wear your plastic suit. I just send 6 feet away from anybody across from you, as well as 6 feet away from. I mean, we're not talking about normal. We're just talking about ability to do it.
Oh, no, for sure. Like I think I just saw like Texas is planning on starting to open up May 1st, and they're talking about restaurants have to be at 25% capacity max. Tables have to be at least 10 feet apart from each other. I mean, it's going to be interesting to see how that plays out.
How do they expect them to stay in business? I mean, that's the thing. You restrict them to that, they have a hard enough time staying in business as it is.
Yeah, when they're full.
I know.
Yeah.
I feel really bad for these guys because it's nothing they did wrong. It's just that we got a situation where if you go to the restaurant and you're tighter than that, I mean, we've done the studies. We know, in a normal situation, a person who sits. Problem is two things. Number one, the ventilation isn't that good in all the restaurants, and number two, you sit there for a long time. And whenever those two things come together and you're crowded, we've done studies that show that one person can infect at least 7 or 8, even if you're pretty far away from them. And so we've done those studies. It's sort of interesting to watch. There's some at MIT you can see that study. At any rate, and then where they had the big outbreak areas in Wuhan, they waited an extra 2.5, 3 weeks. But even now, they're still pretty careful about what they're doing. So that's sort of the cycle. And the big question you have to ask is it once and done? Are we all done now? We paid the price. We should be over, right? Well, we've done the studies, and what we've looked at is MERS and SARS, excuse me. And if you look at MERS and SARS in the wild, we would anticipate actually, and this is their closest relative to COVID, we would anticipate actually that we're going to have to go through this probably 6 times next year in the next 18 months. Yeah, so we've done it once, but probably in the United States we'll probably go through it another 6 times. So we're going to have to figure this out pretty quick. And herd immunity won't happen. Even after 6, we'll only be about 37% given the kill rate and the infection rates. Yeah.
On behalf of everyone, I just want to say, holy shit.
Yeah, this is probably why people don't really talk about this very much, because it doesn't look very happy.
Yeah, exactly. This is not shiny, happy news. But I mean, so, and you kind of touched on this earlier, I do, and Bob touched on this earlier. I think one of the biggest issues that everybody has is, they want that flag in the ground. They want that definitive answer. And science doesn't work that way. Like that's not how this is going to play out. Because nobody knows. And to your point, if anybody sounds like they think they know, disregard them immediately, because this is a very fluid situation still.
Yeah, just ask them what they got their MD degree and epidemiology degree and how many PhDs they've got after their name, and you can generally get their sense of whether.
Right. Well, 3 months ago, everybody was a constitutional scholar. So.
Oh, I forgot. That's right. But, and this is our best guess based on the closest relatives. So it may not be.
Right.
And if you look at the flu, what happens in the flu is then what happens is the peaks drop in the summer, because after March it gets hot, and the flu virus is actually very susceptible to heat. Unfortunately, the coronavirus from what we can tell, isn't so susceptible. We think it's going to be a slight tick, but we don't think it's going to be like the flu, sadly. It would be really helpful if it was, because it would give us a break. But so far, we see it in India, we see it in Africa, we see it in hot parts of the world, with the same levels as we see in the cold part of the world. That's one of the great. We're a little more low in the summer. So that's sort of, the big question we've got. I'll just show you this quickly because it's important to the discussion about IT and AI. What's interesting about this is that it's a little bit of a different take on exponential growth. So what happens is, suppose today you see one death, right? Well, if we think back about the coronavirus, that guy took about 4 or 5 weeks to die.
Right.
Right. Now, at that time, if you do the math, if you have a case fatality rate of 1%, and you go through the cycle, that means you probably have 100 people at the time, right, that were probably sick because you have 1% fatality rate. So now you've seen that one person come out, and so that means you had 100 people right there. At 4 weeks ago, you had 100 people with the disease. Well, if it doubles every week, then in week 2, you got 200 people. Week 3, you got 400 people. Week 4, you got 800 people. And a day, you're off the page, right? So the problem with using death as an indicator is that it's a really latent trigger. So right now they're starting to say, well, let's take a look at infection rate. Now that's a better trigger. We want to have 14 days of infection rates going down. And that's a pretty late trigger, because the problem is we don't have a very good diagnostic system. As I said, we do our diagnosis, and then between 5 and 10 days later, sadly, if you go to a doctor, it'd be 9 days. If you go to a hospital, it'd be 4 or 5. Then you find out whether you have the problem, and that's already allowed. That's another week or so.
Right.
Even after you starting to get symptoms, which is already a week in. So what we have to do is we have to get these triggers going earlier. And I'll talk a little bit about those triggers. Those are diagnostic tests that we do in the field, so you actually know where you stand already at like day 3 or 4. So that way it's easy to stop. If you wait until you see a death, and then if you're not really sure, and you say, well, let's just see what happens and wait another week. Well, now you're at 3,200.
Right.
And let's wait one more week, and you have 4 deaths. It's not that many people, right? Well, now you're at 6,400. And the problem with this is we think that this is a pretty easy. This is a relatively good scenario. We think that the numbers could be 10 times this. So we actually at one death you see 16,000 people are infected. We're not. That's sort of the rate. That's sort of what we're playing with here. The level of unknowns we're at. So that gives you a sense of why these triggers are so important, and why everyone's talking about these diagnostic tests. Because these diagnostic tests, they can push you into understanding whether you got the disease in day 3, not having to wait till week 5. That's a huge difference, and that's the opportunity. And we'll get into how we can use that toward the end. We got some good stuff.
Was that one of the issues in the beginning? Was they just didn't have the tests, so they couldn't get accurate numbers?
Yeah, that's been killing us. We sort of dropped the ball. What happened was we thought that China had it, had it properly done. They thought they were going to be able to stop it. We thought the testing would largely be done in China. The China tests are very expensive. So the big Western companies said, we're not that interested in doing this test. We're going to ramp up, and we'll have to do all this stuff, and then it'll turn out the whole thing will fizzle out like SARS and everything else did in the past. So we're not going to, we don't really want to create these new tests. And that happened in February kind of time frame. And so when it started to really ramp up, like we're taking those 3 weeks before we have that.
We know humans as creatures. Is it safe to say that what happened with SARS kind of lulled us into a false sense of security?
No, SARS was really dangerous. If you go to Asia today,
well, no. I mean, just from the standpoint, like from a U.S. perspective.
Yeah, absolutely. Yeah. I probably would say, we think, it'll probably die. Meanwhile, the Asian countries were really ready for this, right? They had the laws in place. They'd done the SARS. They had a lot of deaths, and so they were ready for a lot of this stuff, and so they were able to stop a lot of it early on. We were sort of, as you said, lulled into it a little bit, and we lost that month in February, and that really hurt. But it's recoverable. It's just it's a lot of fatalities. So one of the things that's sort of interesting on the IT side is how you do these diagnostics, right? And you can start to see, President Trump said today that he wanted us to be able to test about 2% of the Americans. My numbers are we're going to have to do a little bit more than that. 2% is a good start, but to really control the virus, you really have to probably be doing, this is a test per week, so that's about 20 million a day, and he would be down at about, 6 million a day. So, I'm recommending kind of 3 to 4 times what he would recommend initially, but that's a good start, right? So we have 3 different kinds of tests. The first is surveillance. You come in, and so if you go to a bar in China, they'll actually take your temperature often about, see whether you're, and they'll take it outside the bar. And actually, if you go to the best hospitals today, they'll also do the same thing, right? They want to test out whether
before you even walk in the door, they're checking your temperature and that kind of stuff now. Yeah.
Exactly, and that's good practice, right? If you see that, that's a much better situation than if you walk in the door and then they start taking the temperature, or they don't take the temperature at all.
And wander around the building, and we'll figure it out after you've already come in contact with a few people. Life's good, yeah.
Then you got problems. But if everyone's taking your temperature, this actually reduces, in Singapore, this reduces the number of cases by 58% in the hospitals that did this versus not. So it's a very effective means of controlling viral load. It's very sensitive, not very specific. So just because you have a fever doesn't mean you got
right.
COVID, but it's a good start. And especially if the best practice is they test you outside in the parking lot, and then if you got a fever, they say go get a test, and don't go into the building, and that's the best practice.
Yeah, I still have to, Fred. I still have to see my orthopedic doctor because I still have some problems with my knee, and they wouldn't even let me open the front door. Like they had someone open it for me, tested me outside, made sure I was fine, and then inside, like half of it was roped off, and you could only go here.
Good for them. No, that's really good practice, especially if they're maintaining distance all the way through in the waiting room and everything else. That's nice job. That's a really good job. Yeah, so that you're going to a good guy. The other thing I'd say is if it's all possible to do it telemedicine wise over the internet, that's even better. Obviously with orthopedics, you can't do that. They got to test certain physical capabilities you're having after the surgery. But for if you're doing psychological work, or if you're doing normal just diagnostics initially, to the extent you can do it with a telemedicine, you're better off right now just to do it because
for sure.
Yeah. So there's a surveillance test. That's and the other kind of surveillance test is actually what they call sentinel testing, and they'll actually they'll say we're really interested in opening up this building, and so we're going to really do a real this area. We're going to do a real high density testing just of that area. So they'll rope it off and really look at what's going on in that area. That's sentinel type of testing. We have to do a lot more of that, especially if you want to start to preserve some areas of economic activity. The PCR area is sort of interesting. That's the test for the actual virus. So and this is unfortunately this is the area where we lost a little bit of time. And we need to do about 75 billion tests a week or so on this. This is to manage the demand for viruses if we're actually treating them. There are other numbers that say, I'm an epidemiologist, I'm just interested in sort of knowing what the prevalence of the virus is. Then you can do it in a much lower rate of testing. But if you really want to manage the test, you got a COVID patient in your doctor, you're going to have to measure him or her, the patient, 5, 6, 10 times to understand what the level of viral is before you release that. So it isn't just an epidemiologist; it's just once, right? That's the prevalence.
Gotcha.
But if
I'm like, okay, so you're testing the entire population every 5 weeks, but now that it's multiple tests. Okay, gotcha.
Yeah. So, and then what happens is you do more surveillance testing, all of a sudden doing an awful lot more PCR testing because people are thought to have the disease because they have temperature. And in truth, only about 30% of them will have. So you're over testing by a lot. But you have to do that if you really want to manage the disease. So that's why you see the difference. Harvard comes out and says, "Oh, we have to do 5,000 tests a day," and I come out and I say, "Well, we have to do 20 million tests a day." That's not the right number, but that's the reason of the difference. I'm trying to manage the disease; they're trying to understand the epidemiology of the disease. It's two different functions. So and eventually what's going to happen is we'll have. In Singapore, they have something called you can check it out on your mobile phones. It's called Trace Together, and basically it's an app on your phone. You call it down. You can do it right now, and it'll actually tell you when you get within 15 feet of somebody, about 6 feet of someone else's Bluetooth. Yeah, and they have tokens. The tokens dissolve after 14 days because that's about the incubation period. And so what happens is you get if you're within 15, you're in 6 feet, then your phone will pick that up, and it'll say, you're within, and it won't, it'll just tell you the number of the person, right? It doesn't have to identify them if you're on a subway or something.
Right.
And then it'll register it for the next 12 days. Now, if that person gets sick, or say you get sick, it'll tell everybody who's within that, who got the bleep, that, hey, you better go get tested because it turns out someone you got within 6 feet of came down with the disease. It doesn't have to identify who it was or anything like that, but it'll let you know, better go to the doctor, check it out. So that is what that looks like, and it's called contact tracing. And if you look at what Apple's doing and Google are doing, they're coming together and trying to create this and actually make it part of the base of the new releases of their phone. So if Apple just announced they're going to wait for 4 weeks, and they didn't say why, but my guess is part of it may have been that they want to have the next 4 phones they have with this capability embedded in their operating system, rather than to have it as an app. So they can turn it on and turn it off, and Google's doing the same thing to manage the data. So it's sort of interesting the way this is moving. It'll still maintain your privacy, and what's interesting is these contact traces go into a national registry. We already have a vaccine registry. People don't know, but every time you get a vaccine shot for your child, it goes into a national registry. So we already have these registries set up, and it would be nice if we could expand that to include a registry for COVID to understand what's going on. And after the 12 days dissolves, and you continue, that window then continues moving forward. And what's nice about that is if you think about all the work you have to do if you come down with COVID, everyone who you saw for the last 12 days, you've got to go sit down, say, who'd you see? Joe and saw Sue. And then you got to visit Joe and Sue. And then you say, oh, Joe, oh gosh. And you saw how many people? And all of a sudden, you're
right.
And in order to do it right, you've got to, if you see 20 people in that period of time, you have to at least trace 6 of them, and it's better if you do 12. So that's sort of the absolute minimum to understand what the spread rate is. So if you have this, you're all ready to go, right? You don't have to, you've got it all done, everyone goes to the doctor. And eventually what's going to happen is, if this is a significant disease, and we're not sure yet, it might all blow up, but if it's a significant disease, my guess is that you're going to have a diagnostic test that's saliva-based, and you will spit into a cup. It'll register whether you've got any antibodies or have any traces of COVID in you that are active. And if you do, it will automatically register you and your phone will then send them say, okay, please quarantine yourself for 14 days or go see a doctor to confirm. But if you are negative, then you can go and do whatever you want because you're negative. You can go and do your stuff.
Interesting.
So I think that's what it's going to look like if this becomes a serious, a serious pandemic with a high fatality rate. So that's that's a little bit of the IT. What's interesting is you can imagine that, when we do this in more controlled areas, we have AI systems that actually help us predict where the disease is going to move and how fast it's going to spread and so on based on some real numbers. We don't have those numbers yet, but if you can imagine, you'll have a training data set of 80, 100 million data points, and you can train a pretty sophisticated algorithm pretty quick against the hundreds of millions of data points you'll have in the future. So anyway,
that story that came out with Apple and Google, and they're grading the states on being separated. Was that accurate, or was that just for media stuff, or was that? I guess
No. In fact, I'll show you some of that. Great point. Why don't we? I'll show you one more slide, and then I'll show you where we're at.
The one you showed this afternoon was actually really, really fascinating with the Oakland County stats.
Yeah, and we'll show that. It is cool, but they do admit Oakland County said they don't have quite enough data to do everything they'd like. So I'll show you one last slide. This is the way China works it. They're ahead of us. They've got a self-report, a surveillance capability, and a contact tracing capability. If you feel sick, you get shunted into a test, and usually they're finding about 30%. This is at the height of the problems. They found that 30% didn't have COVID. They went to the hospital, they went home, but 70% did. And if you weren't feeling good, you'd go right to a triage clinic, and you'd be either in a field hospital, which is more like a tent set, or a hospital if you're really ill. Or if you weren't feeling so bad, you go right through a quarantine isolation system. They don't really have telehealth. That's something what we would do in our country, but they don't have full telehealth. So they basically quarantined everybody. And then what happens is that's sort of the current infrastructure. What you want to get to is a very precise monitoring capability. And I'll show you what the starts of that look like in the United States right now. But you can get a sense of, you're trying to protect the very high risk patients all the time with whatever you can in terms of herd effects and other capabilities. You've got lots of local tests. You've got vaccines that eventually are going to come in, and you've got a lot of registration occurring. So that gives you a sense, and I'll show you how that looks right now for our state. How does that sound? So I'll skip this. I'll turn off here.
I thought I'd just let you know I've gotten quite a few messages from people so far who say they usually drink while they're sitting around watching our show. They are drinking a lot more listening.
Oh no! I'm sorry to tell you all this. Yeah. That same thing happened at Harvard. They weren't very happy with me. Well, it's nice. At least it's something to think about. You can, as I said, no one knows the whole answer, but this is probably likely to come into being.
I mean, this is A, it's scary stuff, but I mean, B, it's fascinating, and it's stuff people need to know and they need to understand.
Well, why don't I shift to to where we are in Michigan? How does that sound?
Perfect.
Okay, we'll do that, and let's take a look at how we're doing. So this is the beginning of precision monitoring, and so what we did. So right now I'm working with 11 states, Department of Defense, 4 countries, to kind of help them with the way they're managing their situation. And unfortunately, it's not Michigan. It's actually probably a good thing. Michigan's actually probably a little bit ahead, right? Because we've had a big outbreak, and we've got a lot of good people here, but other states aren't quite as strong as we are with our epidemiology capabilities. And so but at least this is some of the data that is readily available. And by the way, this is all readily available. It's all online. It's all real time. You can take a look at it, and I'll just zip through it pretty quick. How does that sound? So
awesome.
Here's COVID. So the first thing you want to understand is how much in control is the virus. And the way we look at this is something called reproductive rate. And reproductive rate at 1 means that the virus is reproducing 1-to-1. It means it's sustaining itself. If you go to below 1, it means it can't quite sustain itself, right? Because it's dying out because it's not reproducing as much as itself. If
Gotcha.
you're over 1, then it'll expand, it'll grow. So you can see back in March when we started this, we were up at an R of 3.5. That's a pretty big R. That means you reproduce every time one person gets a virus, they'll infect 3.5 more. And that's a dangerous rate. And of course, we had a big outbreak here at that period.
Right.
You can see that then Governor Whitmer put in said, nope, it's March. I think it was March 15th. We said no more. Let's stop this thing. And you can see it had a big effect. So this is the effective reproductive rate. But that means that there are 2 different numbers. R is reproductive rate, natural state. We think it's about 2.37. Unless it's got a lot of people to go after, which it did in this case, who are susceptible.
Right.
And then what we did is we started socially distant. So RT, this is the RT number. RT is actually the first derivative of R. So it actually measures the change in R under stress. And we put the virus under stress by separating. We didn't allow it to reproduce, so it was under stress. And by separating, we actually got a reduction in what they call the effective reproductive rate. This is looking at the effective reproductive rate, and you can see that basically we are doing good, and basically we were saying early April, things are looking good. Look at that trend line, right? It came down, and then we started popping up, and you can see where we went over the line. Unfortunately, that was that weekend where we were getting antsy. People were complaining. They were having they had a
the weekend everybody wanted to plant their gardens and put their boats in the water. The weekend it snowed. Yeah, no, absolutely. We're right there with you. Yeah.
And they had some get together. Had some get-togethers in Lansing, and everyone was feeling Lansing because it was a beautiful day, and that's what happens. We all wanted to go out and check it out. So sure enough, we could see the bump up a little bit, and then Governor Whitmer got on the TV and said, "Hey, we got to stop this." And sure enough, we were getting back in control, took it more seriously, and you can see the dump down. And this weekend. I guess it was a nice weekend. I can't remember now. I guess it was pretty nice. I was working. I work pretty much 24 hours a day these days. So as I recall, Sunday was pretty nice, and probably we wanted to go out again and have a nice time. So that you can see that it's quite a sensitive test, and for the IT people, this is actually on GitHub, and we developed this as part of the H5N1. And if you go to my website, you can actually see the original papers we created around trying to look at effective reproductive rates. And what we do is we use a 7-day window of the data set. So we have a moving 7-day window. We take a look at the last 7 days. We average it all out. There's also in the more advanced in the more advanced models, we actually have an annealing function that eliminates the high beta output where you have significant outliers. Those are eliminated from the analysis, but they're put back in again, so we can take a look at the reason for those outliers and decide whether they were true outliers or whether there was a mistake in the data. We have a lot of challenges with this because the data comes in big batches. So sometimes you get up in the morning and you look at the data and you go, "What the heck?" And that's because we're still consuming the data. So give us a little bit of time and it'll start to settle out. But it'd be really helpful if they would tell us we're about to dump a big batch. That would really help our modeling a lot. So at any rate, that gives you a sense of, what this gives you a sense of is how Michigan's doing. And it's all published. It comes out every day. And I can send you, if you go to my website, I can also send you guys the paper. It actually gives you the link and you can take a look at all.
Yeah, absolutely, please.
Sure, absolutely. FredBrown.com. Just take a look. We pick it off, and you can do it yourself. This took me about 15 minutes. About 3 minutes. You can look at it yourself, but actually cutting and pasting everything took a little bit longer. But this is today at 2:00 in the afternoon.
Okay.
So that's that. That's the effective rate. And now I'm pushing the models as far as I can because I want to get to a precision management system I talked about that the Chinese have in place pretty nicely now. We don't have quite enough data to do this really accurately with their model. You can see the gray, by the way, I'm sorry, is the confidence interval. So you can see we're still, it would be nice to have that a lot tighter. So if you're above 1, you can see right now we're just at about 1, but the confidence interval we're having, it could be as high as 1.5. So when you look at that more closely, and this is all the states, so you can get a sense of how we're all doing. I thought I put a yellow box around it. But anyway, Michigan's right, I don't know if you can see it. It's right in the middle, pretty much. New Jersey is on one side, Vermont's on the other.
Yep.
Can you see it? So that's where Michigan is right now. Interestingly, about what I showed you about a week and a half ago, before we had a little bit of excitement about the new weather, we were actually way down on the control side. We were really controlled. We were sort of where Montana is now, Massachusetts, Montana is now, but we moved up, sadly, in the rankings. And you can see that Michigan right now is just below 1, but our confidence interval pushes us over 1. And so we probably, the other thing is, you'll see in the death rates and the other rates that the rates of acquisition of the virus, you can see that we aren't really exactly going down 14 straight days. So for those 2 reasons, we probably have to wait a little bit longer. Hopefully we can hold back and not go out, and we'll get those numbers right. But you can see it's sort of interesting to see who's in control. Interestingly, South Dakota doesn't have any lockdown. They're like Sweden, and they're good. They're okay.
Hey, Fred, what's the deal with New York? I thought they were a hotbed, and it's showing they're almost the same as South Dakota.
Yeah, no, they got their act together, right? I mean, they're managing this really carefully, and people are taking the social distancing really, really carefully, and they've got a lot of control. in the city. I think when you get out in the country, they don't have quite as much control of the testing. The density is lower, and so I would say in New York City right now, it's if you don't take the mass transit and are careful and are wearing your mask and are wearing your garments, it's not too bad. We're seeing a high death rate still, but don't forget it takes 2 weeks for that to cycle through. So it's New York actually is not bad. Actually, I had a friend of mine who called me up today and said, "How's New York?" Because I think about moving out down to Florida, and actually Florida's still not in bad shape either. What's interesting, what's really interesting is California. California, before last beaches, and everyone went to the beach, had a great time, and we saw it in the data right away. So it's sort of interesting that it's that sensitive, and you can kind of get a sense of where things are. It's good to see that we're beating Ohio. That's always a good thing. So that's so you can get a sense from this. Now it's not perfect yet. When we get a lot more data, it'll be much more accurate, but it's directionally correct and it's pretty stable. And we're still working a little bit. If you talk to the Department, well, anyway, I can't talk about a lot of these numbers, but there are some models that are better than this. But this is at least available publicly, and you look at it every day.
Gotcha.
So the question is, how do you get better? How do we get better? And the way we get better is we have more testing density, because then you start to see, you can start to, and right now we can only see Michigan, right? And that's not good enough. We'd like to be able to see our neighborhood. And it's going to be a little bit like, if this becomes a significant disease, it'll become a little bit like the weather map. You get up in the morning, I'll check out, how's the weather? Oh, a little bit of COVID in the air. Okay, well, I'll better wear my protective gear and so on, versus things are looking pretty good. And the way you get there is you have to increase your testing density. And that's what President Trump talked about today. He wants to increase the density, which is absolutely the right answer. And you can see in the 15th, we were doing 3,400 tests a day. We have about 10 million people. This is a test per 100,000 people per day. We have about 10 million people. So we do about 3,400 tests a day. If you really want to get up to what the epidemiologists say they need to get to just measure what's going on, you have to have a minimum of 12,000 tests a day. So it gives you a sense of just how much more we have to go. And some epidemiologists would say, really, I need to get 25,000. I'm not, to really feel comfortable. And for me, I'd have probably about 10 times that if I wanted to treat the disease. So that's to give you a sense of the diagnostics. Then you want to look at, what's interesting is your diagnostics are your first line of defense, right? You find out where the diagnostic, we're going to find out where the bug is. We're going to then be able to attack it with our social distancing. If you get overrun, like we were in New York, for example, your next line of defense is your hospitals, right? Because it moves, and so you have a choice of building out a big diagnostic infrastructure, which costs a little bit, or having to build 100 new ICU units, which costs a lot. Or if you overcome the hospital units, then you actually have to rebuild your economy, and that costs even more. So diagnostic testing probably is a good idea. I like President Trump's decision to increase the density. So
was that story accurate with Kobo? They've only used like 17 of those pods.
There are a whole bunch of reasons for that. That is true. That happened in New York too. It turns out that there was a big issue because you have to give consent. So suppose you're a patient with COVID, and they say, "Great news, you can go to Cobo Hall," and you say, "Well, I'm not really sure. I think I sort of want to stay here. I'm not feeling that great to begin with." So they have to provide their consent. And so the result of that is that a lot of people said that they'd prefer to stay in an overrun hospital than to go and get supported by,
Interesting.
Yeah, so it turned out to be a big factor in New York too. They didn't use much of the ship and eventually they had to ship. Anyway, that turned out to be a big factor, and we'll get better at this as time goes on too. So here's what happened with your hospital density. Everything looks pretty good for Michigan. You can see the green line is the capacity. We didn't have quite as many ventilators as we thought we would. This model actually overestimated how many ventilators you needed. I used the one that President Trump uses because it's pretty good. There's a lot of others out there. I just used this one in the model, and overall, you can see basically we did pretty good. We're past our peak, so home free for this round. So that's good. And then we look at how we do with deaths, and you can see we've gone past our peak by about 10 days now. So we're over the top, unless we have another kind of burst. I don't think we will. We're in good shape, and we're coming back down. And we're probably going to end up. We had an overall fatality rate of about 2.46%, which is pretty much average for the country. So we did good. We did good on the containment. So that's the hospital layer of the question. And so now, if you're the governor, you have to sort of say, well, what's happening with particular area? Let me go into Detroit. And Detroit actually had they were roughed up quite a bit, right? Their fatality rate. This is this is kind of tough, but and you can get a sense of who was affected and some of the key parameters in more detail. And then if you want to focus a little bit more, you can start to look at the economy. And that's the next question, right? Is the cure more expensive than the disease itself? And so what you have to do is you have to say, well, when I start to shut down the economy, this is for Detroit Warren, this is from Harvard, and basically it shows you that we're expecting a job loss of 19.63%. This is for an economy of the overall United States where we're expecting that it's going to go down to about 22% unemployment. So comparatively, Detroit is doing better than average, better than 22%. But you can start to see who exactly is being impacted,
right?
And that's important. So equipment manufacturing, we got to help those guys, right? This is going to be a big problem if there's not coming, if those jobs aren't coming back fast. So they can start to project, okay, if they're not going to come back fast, I've got 30,000 people, 35,000 people I got to worry about. So maybe I need to go and ask for a little bit more federal assistance so I don't bankrupt the state. Those kinds of things you can start to decide. Or do I want to go ahead and open up the economy a little bit, give these guys their jobs back? It's manufacturing. Some of the manufacturing, you can distance yourself, right? You can put on PPE, you're in pretty good shape. Other kinds of manufacturing, much harder. So you probably want to look at can I distance it? And is it really important to my economy? If it's really important and I can do the distance, then you want to do it. If it's really important and you can't do the distance, then you want to protect them as much as you can and probably not do that first. You probably want to do the easy one first. Same with specialty trade and so on. You can go down the whole list and then figure out exactly what your plan is when you know who's going to be affected. So that's how this chart is used in. And by the way, this will all come out in a phone app in a couple of weeks, I think. So eventually you'll be able to click through and be cool. So we'll see if we can get it up. I hope we can.
We're going to need this by the time the bars open so that we can use that for bar arguments.
That's right. This will be helpful.
Then we can settle those bar arguments right then and there. That's what we need.
That's right. What do you mean? I got 6.3%. Right. Exactly. Oh, I didn't move the snail one. So at any rate, that's part of the economy. And then what you start to do is, and this is a little bit more complicated, but what you want to do, remember I talked about boxing in the first slide? I said, we want to create this box, turn off the economy, turn on the economy. So the question is, how long do you turn it on, turn it off? And eventually, this is a different state. But this state said, I want to turn on 2/3 of the time and turn off 1/3 of the time. And I'm anticipating my employment level will be 84% when I'm on and 60% when I'm off. And so here's my target box. Here's where I am right now. They were actually at about 0.6. So they were already closing down a lot of their important locations. They want to open them up. So we said, you can open those up. That you're looking good. You're in pretty good shape. But if you're going to open them up, you're going to have to make some compromises, right? You're going to have to make a decision whether you want to have the Billy Joel concert, with lots of people, or whether you want to, have your electricity on. Because I'm joking. It's not that bad, but you're going to have to make some decisions about what are your priorities and what do you want to turn on, what do you want to keep off.
Well, where do you want your risk point to be? That's absolutely.
Yeah, that's right. Is it the bar or is it, is it the restaurant? Or there's going to be some challenges and some tough decisions. These governors are probably going to have to think about this a lot every day.
Yeah, you want to go to hockey games or you want the manufacturing lines back open? Yeah.
Yeah, right. That's a good example. That's a great example. Or can I do a little bit of this and a little bit of that?
Yeah.
And the answer is yeah. We can get there. But you have to decide what your unemployment rate is and how abrupt you want to make these on and off. It'd be nice to kind of modulate rather than really have to say, oh my God, we got to put on the real brakes because we overdid it. And then that's very painful. But if you can sort of turn on, turn off different sectors, do it right, keep enough people going, then it feels pretty good. But it won't be perfect. Like I said, we're talking about probably overall the economy will be down like 20, 25%. I hate to say it, even if we do it pretty well.
Yep.
But that's if this is a really terrible disease. Now, it's not as bad bad as we think, then maybe we don't need any of this, but at least we're planning for it. At least we have the testing density up there, so we can at least just make these decisions. You can start to see, you probably want to continue self-isolation, all the quarantining. You want to shield the over 70s and the contact stations. You probably don't want to have public gatherings unless you really choose carefully.
Right.
School closures, you probably want to keep the schools closed. You might want to do, you can open, like Germany, they decided to open them up for the final exams, but that was it. So,
but then canceled Oktoberfest.
But then they, oh, that's a bummer.
Which Bob is super, super angry about.
Yeah, especially the one in Stuttgart and Munich.
That's his trip that's his pilgrimage to Mecca is Oktoberfest.
Getting on a plane these days is tough. I don't know if you want to get on a plane for 7-8 hours to get over there. Swimming is tough too. So at any rate, it's maybe good that they decided to let it go. Anyway, that gives you a sense of this. So a lot of this is going to be whether or not how good you are at social distancing. Ultimately, it's going to come down to behavior, like we were talking about. And so that was one of the questions yet about Google coming through with their movements. And so this is Oakland County. This is our distancing today. And you can see that compared to baseline, our retail and recreation numbers are actually lower than the average for the United States. We're doing a really good job there. Transit stations were doing better than the United States. Workplace, actually, we're actually more closed down than the rest of the United States. I think because we had a bigger hit than the rest of the United States.
Right.
Most of the United States, 46, 47, but we're at 52. That's big. You can see where we come up a little bit in the middle of the week. What's interesting is, we love our parks, and we're actually, we're out and about. It's, we're been shut in for the winter, and so there are a lot of people at the parks. And so here, you want to choose a little bit carefully. You want to make sure you're not in too crowded a park, and you're able to maintain your social distancing. If you can't, and you're jogging, try to wear your mask. I know it's a pain, but understand that there's a lot more going on in the parks than is typical.
Right.
Just be ready for it, and if you choose a path that most people aren't on. And our retail, grocery, pharmacy, we're actually a little bit below. We're actually going a little bit more to, grocery and pharmacy stores than the rest of the United States. The rest of the United States is minus about 35%. We're at 22%, and like in Wayne, it's only down 11%. That actually is bad. That could come back to haunt us a little bit. So
what I've heard from a lot of folks, I've got a lot of friends in Detroit that live in the city, and they're saying that they don't have the stock issues that a lot of the suburban grocery stores and that kind of stuff have. And so I've seen a lot of friends from the burbs that are going downtown to hit those neighborhood grocery stores. And so, it's almost, okay, you're solving the problem, but now you're cross-contaminating, kind of like the whole, hey, no, don't go to your place up north because they don't have the infrastructure to handle an influx of people, from a densely populated area just in case. So, it's
interesting.
Yeah.
Yeah, so Bob, you were asking about whether this is real, and you can see they've noted in Oakland County they don't have quite enough of the coverage they'd like to. We need to have more cell phone users, but it sort of does suggest what's going on out there. So it's and as I said, we'll try to get this up on a mobile app, and then it'll go to the world because we have all this data for the whole world. So hopefully everyone will be able to use it, and it's all free. And I got to talk to the developers that they may want to charge a little bit, but hopefully it'll be all free for us, and we'll be able to get our weather forecast every morning.
Wow. That's all I feel like I just absorbed, like I just drank from a fire hose.
A little bit about COVID, we can talk about some of the drugs and some of the next steps. If you want to get together next time, I'd be happy to do it, and we'll talk about, because that's really my law. I love, what's going on at, the step 4 of the reproductive cycle of a virus, and how we've got protease inhibitors intercalating the DNA. We can go on all into that.
I will absolutely nerd out with you. So one of my degrees is in biochem. Bob's eyes will probably glaze over. If you can find a way to relate it to beer or Jägermeister somehow.
Well, we can do that. We got a lot of fermentation, we know. We'll start.
I want to talk more toilet paper shortage. Let's get in on the.
Sure.
No. Now, see, my rumor. I got two theories in it. I want you to. One is that now everyone's got to eat their own cooking, so now they got stomach problems. Or two is, one person coughs and then 30 people shit their pants. So that's kind of another reason.
There will be two critical areas of shortage that your listeners should know about. The first area of critical shortage will be in the area of PPE. So if you think about this, right now, the only people who are really competing for good protection are essential workers who have to be out there, like the police and of course the healthcare workers. So that's kind of, we can kind of get by with, say, 300,000-400,000 masks a day. We have to reuse them, and probably the maximum capacity we really have right now is about 4 million masks. That's really the demand for those people needing the masks. But if you think about it, when we open up our economy, everyone will be going back to work. Everyone will be feeling like they're a little bit exposed, and the N95 masks are the better mask. And so I think there's going to be a huge, and don't forget, we're just one economy, that's Michigan. We're going to be competing against all the Europeans and all the Asians for those masks. And so my guess is that, it's not my guess, it'll happen for sure. You'll see a lot of demand for that PPE. And the other big area, especially masks and gloves. So those two areas will be really stuck.
So the one, there was one, I think it was NPR that published, this was actually one of the topics that we always start a new email thread every week with, topics we bounce back and forth. NPR published out a statistical model that said, basically, based on their data, their projections, all that kind of stuff, the opening update for Michigan should be about May 21st.
Yeah.
So that's, and so like right now we've got through May 14th. So how do you feel about that week plus minus? Like, is that within the margin of error or?
Yeah, no. So originally when I did the modeling, I didn't think we were going to be as good as we were. So I thought we'd be kind of dealing with a peak, quite a bit higher peak, and it would last quite a bit longer before we could open up. So originally when I did my modeling, I thought it was going to be kind of out in early May. And, we did so well that actually we pushed everything back and we went through the peak, at a lower level, and we got through it faster, which is great. So a couple of things. First, we didn't get the 14 straight days. We sort of went up in a couple of those days. We have a little bit of ups and downs as the weather gets nicer. We want to go out on the weekends. And so those two things, if we can get that under control and we don't have another upsurge like we did last Friday and this weekend, then I think we'd be ready. But I wouldn't open up everything. I would be really careful about making that decision, right? And that's what I'm talking about with other states as well. I'd say, let's the auto plants, some of our key industries, we want to make sure that we open those up preferentially.
Which in Georgia is apparently bowling alleys and hair salons. That's those are their key industries.
Oh man, yeah. And the problem is they've got a really,
no offense to anyone watching from Georgia or listening in Georgia. I'm just saying.
No, the challenge is going to be the same thing happened in Singapore. Singapore was pretty well controlled. And then we missed I'm working a little bit with them, and we missed a small population of migrants that we weren't controlling very well. And then Singapore is such a huge transportation hub that, people were flying through the airport and it just went everywhere. And now it's completely out of control. I'm really worried. Georgia is actually in control right now, by the way. Georgia's not bad, even though, but they could go out of control.
Oh no, that's actually one of the states I was looking at when you pulled up that graph.
Yeah, no, I was really happy that Georgia's in control, but the problem is they don't have the testing instances they need in order to keep it in control. And we had that huge air base there, the airport there, Hartsfield, and that's a dangerous situation.
Well, and that's one of the things that again, just getting back to the fluidity of the situation, we keep finding out that the first death, in the U.S. wasn't end of February, it was first week of February. And the first exposure here, oh, by the way, we just discovered there were at least a few people at CES the first week of January in Vegas. I mean, there's 170,000 odd people that go to that thing and then fly back to all parts of the world from that. So, and that's like, so I mean, I guess, we kind of jokingly said, hey, the Spanish flu was 1918. It took until 10 years ago before that full pathology was, available and all that kind of stuff. Like when do you think we're gonna know, where this really, where it really started and when it really should, when do you think that's going to happen?
Yeah. So, when it really happened, so it really happened. It really did happen in China. There's no doubt about it. We can trace back all the mutations and see where the first is. We have about 14 options for patient 1. And that's too many, right? You saw the death rate. If you see one patient, you already have 100. So, and unfortunately, there are some theories that, originally I discounted them completely, but there seems to be a little bit more to it than maybe first met the eye, that it could have been an escape virus. I still don't think that's a very high probability, but there is a storyline that says we were trying to go after a vaccine for AIDS, and it would be logical they would try to use this as a vector. That's a theory.
Well, and there's two theories that go along with that theory, though. One is, it was biochemical, it was chemical warfare and it got out. Or what you're saying is they were doing research into it and it got out.
Yeah, the research. See, we think that in the next 10 years we'll be able to have a vaccine for AIDS, and what we like to do is we like to use these vectors that help that get in our antigens as fast or faster than the virus is able to. So we use a viral vector in order to transfect the cells that the virus is going after, so we get there first and they're able to stop the machinery before they reproduce. So that's the way we do it. And there is a storyline that says this would make sense. There are a few AIDS type genomic sequences that are in this virus. But I still give it a very low percentage chance of being real. I think it probably started in bats and went to another animal and probably then went to humans. That's by far the most reasonable explanation.
So that's one of the things that I know the first couple weeks, a lot of the articles and a lot of the stories were, use the word slippery. Yeah. When it comes to describing this virus, and as far as how it was transmitting and how it was mutating, and I kind of haven't seen that in a while. And then of course, Netflix drops The Tiger King, and the next thing you hear, there's a couple of tigers in a zoo in New York City that have it and all that stuff. So I mean, I guess that's the thing, if people are worried about whether it's their pets at home or or that kind of stuff, what's the reality of that situation?
Yeah, no, it is real. The reason we watch is it doesn't sound very significant, but having an extra animal that can, but if it's only in humans, then it only mutates in humans, and it has to. What happens is you put the virus under a certain level of selection pressure in each kind of species that you're in, right? So if you're in humans, there's certain kind of selection pressures that we've got a pretty. We have a population that's pretty diverse, but it's still within, between species, you get quite a bit more diversity. You got quite a bit more different kind of selection pressure, and you have then, a cache of virus that's sitting, waiting, and possibly changing to, be in the cat that then can come back to us.
Yeah, you've got additional mutation vectors, absolutely.
Yeah, and that's why we watch it and take it. It sounds like, the poor kitty cat, but it is something that we take seriously, and it's a concern. I have talked, it's obviously that, one of the things that I really watch very carefully for is the mutation rates. And I'm not as strong an expert in mutation rate analysis as some of my friends are. My friends say, coronaviruses are pretty stable. We probably can find a vaccine. What's nice about it is that it means we can actually hold it steady long enough we can find a vaccine and drugs for it. The problem we have with the flu, pneumonia, malaria, even worse, AIDS, is they mutate so much that you can never find a conserved region of DNA and protein to go after. This one, we think, is not going to have that much rotation rate, but I'm still very concerned and watching it very carefully. There was a pre-publication that came out by one of the top researchers in China that indicates we're seeing a little bit more mutation than we were hoping for.
Yeah. I think the last thing I saw a week ago, they were tracking 11 different strains at the time.
Well, if you want, you can go to I think it's called there's a whole website dedicated to this.
Of course,
watch
yeah.
in real time, and I think it's called New Virus. I think it's called.
Oh yeah. I think that actually might have been where I was a week ago.
Yeah, and it's great. You can watch all this stuff, but in truth, if you think about the population of the virus and how much mutation you'd expect, if it was highly mutated, it's not too terrible. It looks terrible, but it's not too bad considering how prevalent the virus is. And I was worried about there are a couple things that I'm worried about, but I won't speculate on TV. That I'm watching pretty carefully.
So, I mean, what would we be doing as a society if we didn't have Netflix? Because, I mean, we got out of because we got out of 9/11 with baseball, right? I mean, you remember the first pitch, President Bush, Boston Red Sox, the Yankees?
Yeah.
That brought the country home. And now really all we have to do is pray to God that they release more shit on Netflix because we watched everything.
Yeah, Bob, I'm a little worried that they're not going to be able to get the actors together, and the content's going to go to hell fast. So I'm worried about what's going to happen after the fourth iteration of.
I guess I'm watching The Sopranos again.
That's where I'm at, digging out old Kenny Powers. Yeah, like I'm watching just old crap that
I know. I'm doing the same. Well, actually, I'm working about 22 hours a day. It's sort of peak season, obviously, for people who are specializing.
For sure.
I'm one of them. Yeah. So, but hey, it was great. We should get together again. We'll talk.
Yeah, I was going to say. Speaking of which, I did not expect this to go an hour and 45 minutes. And I
apologize. I get excited.
No apologies.
Thank you.
No apologies necessary. This was amazing. Thank you so much for taking all this time.
Absolutely. Pleasure. And hopefully we'll get together again under better circumstances, talk about the drugs, talk about the vaccines. I love it.
Absolutely. You whenever you have an open invite, that's how that works.
We want to get the word out, and I'd be happy to do it. Be happy to participate. Appreciate
it. Thank you so much. Feel free to drop off. I appreciate it.
Pleasure.
FredBrown.com. It's definitely one of I'll put them in top 10 guests we've ever had, and it's been about 6-7 years of doing this show, so that's saying something. So,
yeah, wow.
Really, thank you.
How do we go yuck after that? I don't.
No, we'll wrap things up. It's perfectly acceptable. This is super happy.
Hey, we did have one read in there. Let's make sure we get that in there just to be safe. Even though, yeah, and I'll probably edit it and put it back at the start of the episode just to keep them happy. But hey, so with the Capital One Quicksilver card, you earn unlimited 1.5% cash back on every purchase everywhere. That's unlimited 1.5% cash back on everything you buy, and unlimited really means unlimited. With Quicksilver, there's no limit to how much cash back you can earn. Capital One, what's in your wallet? Credit approval required. Capital One Bank, USA. NA. And I would just like to take a moment to just say that conversation was so fascinating that it is my birthday and this is my second drink. Like I am not and this is the Randy special. This is the Yeji and Mountain Dew. And I did not overdo it.
Awesome.
That was hands down, dude, that next to the one we did with all the folks in from Flint and that the guy that was doing the geological surveys, that was holy shit, that was fascinating.
Indeed. So slow clap for Dave not getting shit-faced during a serious guest. Wow, that's great. You're amazing.
Hey, baby steps. We take the little wins during the quarantine.
All right. Well, happy birthday once again, and we're going to wrap things up for episode 345.
Well, and for what it's worth, I mean, yours is May 1st. Yours is right around the corner, and we'll have we won't have another episode before then. So happy birthday to you, dude. And we do. We need to when this is we need to plan for next year. We need to do another good joint birthday party, because every time I see those pictures bubble up in my memories, that was hands down one of the best birthdays I've ever had in my life, and we need to do that again.
And thanks for everybody for watching.
Yeah, indeed. No fatheads this time.
Nah. Maybe Randy's. Maybe we'll do Randy's. We'll get a fat head of Randy's head this time.
Perfect.
My head's already pretty big.
Yeah. All right. Well, hey, we're going to wrap things up. Episode 345 of the IT and the D Show. Thank you to Fred Brown, FredBrown.com. If you want to look up more of the stats and research as he progresses throughout this madness we're dealing with.
Yeah.
But I guess thanks to everybody on behalf of Bob, Dave, and Randy. Do us all a favor. Drink up your drinks. Get your phone numbers. I guess stay home, and we're going to get the hell out of here. See you next week. Stay healthy and beat it.
Yeah.
Happy birthday, guys.
Yep. See you.